Good afternoon. I'm Diana Toulier, a Technical Assistant Specialist with the PDG B-5 TA Center, and I'll be the facilitator for today's webinar, Supporting Infant and Early Childhood Mental Health Across the Mixed Delivery System. Mental health is such an important topic that affects families, children, and providers. I'm excited about the information that our presenters will share with you today. Next slide. Just a few housekeeping things to note. We are recording today's webinar, including the breakout rooms, so you can view the ones you are unable to attend later on when you have a chance. Please put any questions you may have in the chat. We'll be monitoring that. Make sure the correct microphone and speakers are selected. And please add your state after your name by renaming yourself. I also want to mention that if you registered early, you should have received an email with breakout room topic information as well as today's note catcher. If you didn't receive that email, Sandy is going to drop the link to the note catcher in the chat, so you'll have it to reference and use for notes during today's webinar. Next slide, please. Today's presenters are Jamie Colvard, Allison Steyer, Lisa Schluter, Lana Nanai, Audrey Idecotter, Jordan Murphy, Nikki Edge. Next slide, please. Here's today's agenda. Most of our time will be spent in breakout rooms after we hear from our two subject matter experts. Then we'll come back together and do just a few evaluation questions together before we end. Next slide, please. Our learning objectives for today include having an increased awareness of the continuum of infant and early childhood mental health supports available, learning about state-level efforts for coordinating a continuum of supports that fit together to benefit children, families, and providers, learning about strategies for implementing trauma-informed care trainings for providers and families, and identifying next steps to create a statewide system of infant early childhood mental health that includes private and public partners. Next slide. Now I'm going to turn the presentation over to our first subject matter expert, Jamie Colvard. Thanks so much, Jamie.
Thanks, Diana, and hi, everyone. I'm so happy to be here with you today. I'm the Director of State Policy at 0 to 3. For those of you who aren't familiar with us, we're a national nonprofit. Our mission is to ensure that all babies and toddlers have a strong start in life. And I sit in our policy center, so we serve as a resource for policymakers, agency staff, and advocates at the state and federal levels. And I'm really excited for this webinar because infant and early childhood mental health is really core to our mission and what we do, and has been since we were founded 40 years ago. So on this slide, you can see the 3 areas I'm going to focus on in this presentation. I'll also be in one of the breakout rooms so that we can delve deeper into any of them. Next slide. So anytime I'm doing a presentation like this, I always like to start by answering the most basic question, which is, why are we even talking about early childhood? Why does it matter? And I know that most of you in this room probably are familiar with the bullets on this slide, because that's why you're working on the preschool development grant or other system building efforts in your state or communities. But I feel like it's always important to ground ourselves and remind ourselves that we're talking about early childhood because the early years are so important for development. And we know that a child's first years and the relationships they have really ground everything that comes in the future, and that all domains of development go hand in hand. Next slide. This is a screenshot of an infographic 0 to 3 developed a few years ago that we use to help others understand what infant and early childhood mental health is, and that we all have a role in promoting it. So the definition that we use is that social and emotional development, or infant and early childhood mental health, is the developing capacity of a child from birth to age 5 to form close and secure adult and peer relationships, experience, manage, and express a full range of emotions, and explore the environment and learn, all in the context of their family, community, and culture. And we know that babies' development is happening in the context of their relationships. So when we're thinking about how to promote healthy development, we really need to be thinking about that context. And everyone who touches the life of a child needs to support healthy social and emotional well-being. And you can see on this slide, those little yellow dots are where we're calling out some of the areas of the system where it's important to think about this. How is early childhood mental health showing up? Next slide. So when we're talking about infant and early childhood mental health, or I might start saying IECMH, we like to describe a continuum of relationship-based activities that increase in intensity as you move along the continuum. So promotion is really involved in raising awareness of the critical nature of mental health and encouraging positive IECMH development. Prevention can involve screening for and identifying risk factors or mitigating the impacts of adverse childhood experiences and providing caregivers such as childcare providers mental health consultation. Assessment and diagnosis involves providing a thorough assessment and accurate diagnosis using a developmentally and age-appropriate classification, such as the DC 0 to 5. It's important to note that we're not talking about diagnosing a child, we're diagnosing the condition. And then finally, treatment is the most intensive on the continuum, and it's providing evidence-informed services and supports intended to directly address mental health disorders. Treatment is often aimed at supporting or repairing a primary attachment relationship. So for example, child-parent psychotherapy, CPP, and parent-child interaction therapy, or PCIT, are examples of models. Next slide. So there's many actions that states can take to advance investment and services along the continuum. And we can talk more about this in breakouts if people are interested in, but some of the trends that we've seen are really a focus on looking at states' Medicaid systems and supporting Medicaid payment for prevention, promotion, and treatment services. That may include looking at encouraging or requiring use of a developmentally appropriate assessment tool and making sure providers know how to use that and have the supports they know to put it in place. It really is thinking about training the workforce of professionals working with families, thinking back to that infographic across the system to ensure they know how to identify early warning signs and connect families to support. It's also really embedding practices focused on social and emotional health in child serving systems like primary care, child welfare, and housing. And then a place that we've really seen a lot of movement recently is building a system of early childhood mental health consultation across settings where children are. And that's what we're going to dive into next. Next slide. So this graphic is from the Center of Excellence for IECMH consultation at Georgetown. And it really lays out what consultation is. So consultation is a prevention-based service. It's pairing a mental health consultant with families and adults who work with infants and young children in the settings in which they learn and grow. The aim is to build the adult's capacity to strengthen and support healthy social and emotional development of children early and before more intense and expensive therapeutic intervention is needed. It also builds the capacity of professionals to support adults who have experienced trauma, stress, or have their own mental health issues and are now parenting. Next slide. So, where can early childhood mental health consultation take place? From a systems view, ideally, it's anywhere that an infant, young child, or their family receives services. Depending on the setting and sector, the delivery would look a little bit different. But it's most often recognized as a strategy in childcare settings. That's where we've seen the most movement, but we are now seeing states explore other areas as well, such as Part C early intervention, home visiting, child welfare, and other areas you see on the slide. And what it looks like in practice, in childcare, for example, sometimes consultation is focused on a specific child, helping the adult support that child's development more effectively. Other times, it's really focused on systemic issues, such as improving the classroom environment to provide predictable schedules, creating smoother transitions, or creating spaces in the room for children and staff to calm down during stressful periods. It might also focus on helping a childcare provider foster stronger relationships between the providers, parents, and children. In home visiting or early intervention or child welfare, consultants may focus more on supporting the providers through case conferences or reflective supervision or group trainings. Next slide. I want to talk a little bit about why consultation is important. What do we know about why it's needed, and then also sort of what the research shows about the benefits and outcomes of it. So to start, here is some data from childcare. And for many people, these are the kind of stats that really get their attention, especially policymakers when you're trying to make your case. So just to walk through these a bit, researchers estimate that as many as 1 in 5 children in childcare have serious difficulty managing their emotions and behavior, and more have challenging behaviors that may be compromising their ability to learn. We also know that young children in childcare are expelled at a rate 13 times higher than K-12 expulsions. And we know that that's not being experienced the same across all children. Black children are disproportionately represented in that number. Research shows that the rate of expulsion is 3.5 times more likely compared to white peers. Now, expulsion is an area we've seen movement in states over the past several years to address it, some by banning expulsions and suspensions, but we know that creating a rule that you can't use expulsion or suspension anymore isn't enough. Childcare providers really need support in knowing how to support children and how to manage their own stress and responses. And then this last area on this slide is sharing data about childcare providers' reported levels of stress and burnout. And this research was showing 1 in 3 providers report that. This was from before COVID, so we know this number has only continued to increase. So addressing childcare providers' stress and burnout is also an important thing to pay attention to. Next slide. I also wanted to just include this quote from a home visitor who's involved in consultation, because I think it brings to life a bit about how the partnership is helpful to their job. I'm just going to pause and let you all read it. I think this quote can easily translate to other settings like Part C, child welfare, and pediatrics. Next slide. So what does the research tell us? You can see here some of the research findings when there have been evaluations of consultation. Most of that research is in childcare, so that's where the majority of this comes from. But we can see that consultation leads to improvements in teacher-child interactions. Several states have reported improved classroom climate after consultation. We see that children may increase attachment and self-regulation skills, and behavioral concerns go down. And also that early care and education providers are able to manage children's behavior more effectively. They increase their skills in being consistent and being attuned to children and providing safe care. We also see rates of expulsion and suspension going down. And then we see impacts for families too, where they miss less work and report lower parenting stress. And again, we see that showing up in teacher stress as well, and lower rates of turnover. Next slide. We also see more systems level benefits. Often implementing consultation in a system is an avenue to address implicit bias and systemic racism. It's a way to model reflective practice and put those supports in place within systems where they don't already exist. Often consultants may be the only ones in a room to ask questions about trauma history and how that might be impacting a child's behavior or a professional's reaction. And then again, consultation can provide a way to identify red flags earlier and refer families to services sooner rather than waiting until they're caught, say when children reach school. Next slide. So this slide really is summing up some of what we've been talking about. Consultation is about supporting the adults that work with families and children. And that looks different in different settings. So in childcare, a consultant might help a teacher understand and respond to a child's behavior, look underneath the behavior to understand what's really going on. In home visiting, a consultant might be supporting a home visitor recognize how the parent's history of being in foster care and their mistrust of the system might be contributing to their mistrust of the home visitor and help them to really build a strong relationship so that their work can be more effective together. Or in pediatrics, maybe the consultant is helping the doctor or the physician assistant understand the possible underlying attachment issues behind a child's failure to thrive diagnosis. Next slide. So what we're seeing in states, I wanted to highlight some of the trends we're seeing in states to support IUCMH across the continuum. And some of the things, we have links to some resources on a later slide, but some of the things that we've done recently to identify some of these examples I wanted to lift up. One is we did some interviews with states about their use of American Rescue Plan Act funds, and we saw some use of those funds to expand consultation, to increase clinical capacity, and really invest in state infrastructure. And in the breakout, I can go into more detail about some of the specific examples of these if folks are interested. We've also been part of a group with other national organizations analyzing all the preschool development grant birth to 5 plans and have pulled out some of the infant mental health focused strategies in those. And those have really centered around 3 themes, really trying to understand what the current landscape of services looks like and make priorities for what will come, what the state should invest in next. Building infant mental health capacity, again, either looking at clinical capacity, say maybe training staff on program for infant toddler care or CPP, or supporting childcare providers to receive their infant mental health endorsement, or expanding consultation. And I am guessing that some of you on this call are involved in some of that work, so would love to hear more about it. I think we saw in some of that, both the ARPA and the PDG analysis, that we're seeing states that maybe had piloted in a few communities before, now trying to, using these funds to expand those pilots to additional communities, as well as thinking about other service systems. So maybe they started in childcare, but now they're looking at early intervention or home visiting, or they're trying to think more systemically, looking across settings about how they can kind of make a more systemic infrastructure to support that. Another area where we're really seeing states move forward is thinking about policy changes in Medicaid. And the best example of this most recently is in California, where Medicaid will now cover integrated physical and behavioral health screenings and services for the whole family, not just the child who's the identified patient. This expansion is really important for families where a child might be covered, but the parent or caregiver is uninsured. And then it allows dyadic services. California is also adding doula services to the list of services that can be covered by Medicaid. And that's a step we've seen a handful of states take recently as well. And then finally, just really taking a systems lens and thinking about how infant mental health can be embedded across systems. I think you'll be hearing from some of the states today that we often point to as those that do a great job of that. But strategies we've seen states take might be creating an infant and early childhood mental health position that works across agencies, strong partnerships between state agencies and infant mental health associations, and thinking about infant mental health endorsement. Next slide. And I think I'm at time, so I'm just going to close by showing the slide with some of the lessons learned from the states where we see policy progress. These are some of the things that they have called out that are really important to focus on when you're making policy change. And I think the two that I would just lift up as most important are to really center equity in design, implementation, and evaluation. And as part of that, how critical it is to, at the beginning, listen to families and providers to really understand what's working and what's not right now, so that the solutions that you're pursuing are really the ones that families and those working in the system think are the best to pursue. And I think my last slide is just resources, so you guys can look at those later. I'll hand it back to you, Diana.
Thank you so much, Jamie. And I do want to point out that the resources on her resource slide are in the note catcher as well. So if you will advance the slide, please. Next slide. All righty, we are at our next presenter, Allison. So take it away.
All right, thank you. Well, I'm delighted to be here today, and thank you for inviting me and taking some time out of your day to hear what I have to say about trauma-informed care for parents and for early care and education providers. I'm going to use the secret code to advance my slides. I'll say, next slide. Thank you. Okay, so let's just remind ourselves of the definition of trauma-informed care or approaches to care. These are practices that realize that trauma is alarmingly common. And the way these are organized, these practices are organized, are they all start with the letter R. And this is SAMHSA's contribution, that the 4 R's of trauma-informed care. So what is this realization that it is quite common, and that early childhood trauma has a long reach into the lifespan. And there are also avenues for healing. We also recognize, in settings that are attuned to this idea of trauma, we learn to recognize signs and symptoms of trauma, not to diagnose, which is more complex sometimes than we might realize, because a lot of symptoms in early childhood are non-specific. The same symptoms can indicate a lot of challenges, different kinds of challenges. Sleep disruption, for example, can be just that, or it can be associated with trauma, developmental disorders, and so on. So it's holding in mind the possibility that what we're seeing in a child may indicate trauma, the possibility of that, knowing how common it is. Responding by taking our knowledge of trauma and applying it to policies and procedures and practices so they can be more sensitive. And the final R, that we are then able to resist traumatizing or re-traumatizing people, because we have eliminated or more attentive to things that may be triggers that we can do away with. So this is a shift in mindset from thinking about what's wrong with that kid to thinking empathically about what may have happened. And we're aware, of course, that it's not just children, but many of the adults who are caring for children who have also been exposed to trauma. Next slide, please. So I have been asked to talk about trauma-informed care with parents and providers. But given the definition that I just gave, I have to say that I actually think we should be doing it with everyone. So these are all the jobs, just the jobs. They're just the A's. We haven't even gotten to, you know, baker, banker, and barber, let alone zoologist. I know it's probably concerning to you that I know these jobs in alphabetical order. So today we'll just talk about parents and providers. But the idea here is that trauma is common. In the United States, about 61% of men and 51% of women report exposure to at least one lifetime traumatic event. It's very high numbers. It's also true, and I'm going to quote now from the diversity-informed tenets for work with infants and children and families. And I think you probably are familiar with this document. If you're not, I would highly recommend that you look it up. You can find it online. But we have 10 principles, 10 tenets for work with infants, children, and families that are equity centered. And the second tenet reads like this: infants and children are citizens of the world. The global community is responsible for supporting parents, caregivers, families, and local communities in welcoming, protecting, and nurturing them. Everybody's responsibility: accountants, actors, actuaries, acupuncturists. But we'll talk today about parents and early care and education providers. And also, I don't actually know what an actuary does. Next slide, please. So our kind of bottom line, modest ambition with trauma-informed care is to help children and not make things worse. With awareness, parents and early care providers, and those of us who provide mental health consultation, can support early care and education settings, and we're well positioned to do this, to help in 3 particular ways. And there are probably more, but what I was thinking about is where we can prevent trauma, and we can support parents in preventing trauma and protecting children's mental health. We can support parents and providers to recognize trauma. And I'll give you an example. I used to do a lot of assessments and treatment of parents whose children had been removed for substantiated abuse and neglect. And when I would interview them and ask them, has your child had any setbacks in their development? Often they would say no. They would say, no, these are children who have been removed because we know that there had been abuse or neglect. So we often have blinders on because it's very hard to acknowledge that children have suffered. So in trauma-informed care, the idea would be to support people to be able to face that fact squarely. And then to respond to trauma. Next slide, please. So what do parents and providers need to know? I mean, these are some of the risk factors for child abuse and neglect. And some children may be more vulnerable based on their individual characteristics of their life circumstance. Isolation, we know, is famous for being a risk factor to families. Alcohol abuse, domestic violence, and so on. You can see these. This is important information for people to know. These things do not equate to trauma. This is not, you know, if you have this, then you have been traumatized, but they are risk factors. Next slide, please. and there are protective factors. And mental health consultants are supporting childcare providers to strengthen the protective factors in children's lives. So when you have strong social and emotional skills as a child, which preschool can promote and help provide, then children are able to identify and value their feelings. They have a sense of personal boundaries. They have a sense of that certain adults can be trusted, that they have something going with them. They've developed a trusting relationship, and that they can then talk to those adults about uneasy feelings, about fears, about their concerns. Being able to do that is a protective factor. It makes the child less vulnerable. It's one of the reasons that social and emotional learning in the early years of life is so important. And parents can do their part to promote an openness with their children, so their kids can feel they can come to them and talk to them and have a greater sense of being able to to feel effective in the world and to feel entitled to safety, which of course they are. Next slide, please. So this is, mental health providers and mental health consultants. This is our daily fare. This is work that we do. And certainly in my state, in Arizona, we have one of the largest statewide systems of mental health consultation. And we aim to influence the culture of early care and education settings to be more trauma informed. So in programmatic consultation, we're often talking about center-wide policies and practices that can be modified or eliminated sometimes because they don't serve this function of being protective around the possibility of trauma. And also, it turns out that what's good for children who've had trauma in their lives, pretty much good for everybody. Next slide, please. So the second way of helping is helping people identify signs and symptoms of trauma. And as I said, if you look at this list, irritability can be 1,000 things. Clinginess, separation, language delay. The point, though, is to consider the possibility that what we may be seeing is trauma, and to be thinking about what is the communication of behavior, what is the meaning or multiple meanings of behavior, what are the needs that children are conveying to us through behavior. So holding this possibility in mind, retaining it in mind, it can be a fifth R, makes us better able to identify and reduce the symptoms of trauma and support recovery. And wouldn't it be great? And I think our aim with high quality care is to have environments that do in fact support children's healthy development and a return to a healthy developmental trajectory where there has been damage. I think next slide, please. So we as mental health providers can strengthen trauma-informed practices in early care and education settings by the things that we do and by the way that we are doing and being. So examples are establishing clear mutual expectations for the mental health provider teacher or mental health provider director relationship. In Arizona, we talk a lot about a letter of commitment. That letter says, in effect, this is co-created with the child care provider. It says, we're in a relationship, and relationships have accountability. So here's what you can expect of me. I'll be on time. I'll come on Tuesdays if that's what, I'll work in the twos room. I'll meet with you You know, I won't just walk into the center because you're the head of household. So I'll always check in with you. We'll be in good communication and we'll get to know each other very well. And things like that. And here is what I would expect of you, because consultation is, it's relational. It's not a spell you can cast. It's not magic. It will take us working together. So things like that also give people a feeling of power and say so in the work. And we, again, holding in mind that the teacher before us, the director before us, may be a person who has been exposed to trauma. It is no good to take power away from people who have felt powerless. So from the beginning, we're establishing this as a partnership. And then from a being standpoint, all the ways in which we comport ourselves that say, I have expertise. I don't deny it. I spent a boatload of years in school, but I don't have I'm not the only one with expertise. And so I'm going to solicit yours. I have respect for your expertise. And so on, other practices too. Next slide, please. So one of the ways that we support a trauma-informed early care and education environment, or these are ways in which we do it, is to help the setting establish safety in the classroom, sort of overall culture of safety and trustworthiness, predictability. So we encourage schedules, and people who've been exposed to trauma do not like surprises. But you know, most of us don't love surprises. So again, trauma-informed care, good for everybody. Building trust by listening well, by following through on our promises, offering choices. Again, that feeling of, you know, I'm not here to tell you what to do. This is not a paternalistic or parentalistic kind of stance I'm taking. I want to offer you choices in what you want to do. And I want you to, you know, let's think together about how you offer children choices. And self-regulation on the part of teachers and directors and the consultant, of course, because it encourages self-regulation in others. Anxiety and dysregulation are very contagious. If you've ever seen the movie E.T., there's this great scene where the little girl walks into the closet and sees E.T., the extraterrestrial, and she screams. And then E.T. screams. And then the brother screams. And then the other brother gets thrown against the wall and all the books come down. I mean, it's this cascade of distress and dysregulation. So that's the bad news. Thing is, regulation is also contagious. So strategies that we can help teachers develop to maintain or return to regulation, super helpful for individual children and the classroom climate overall. And there's no bullet point on this slide that isn't relevant to parents as well. Next slide, please. So I mean this from the bottom of my heart. There's no more important message about trauma than the fact that people can get better. We have many evidence-based models of treatment now. We are tuned in to the fact that we can help create environments for children that promote recovery and healing. And one of our jobs as mental health consultants is to kind of sell people on the idea that that's the business they're in, establishing a context for development that supports children's feelings of control, efficacy, safety, and turning them on to relationships with adults that have their best interest at heart and are trustworthy. So I think I'll end here and look forward to the breakout session.
Thanks so much, Allison. You shared lots of really great information. That takes us to our first poll question. Marissa, if you'll pop that poll up. So if you guys would, we want you to indicate how you feel after hearing today's two initial presentations. If more than one applies, feel free to choose more than one. And we'll just take a couple of minutes, let you guys give us some feedback. Well, I'm excited to see that almost half of you have gained new information from our first two presentations, but I'm equally excited that you guys want to hear more about these topics, because hopefully that's what will happen in the breakout rooms. Okay, Marissa, I think we can go ahead and end that poll. Thank you guys so much for your answers. Okay, so next we're going to go into breakout rooms. We're going to spend the next 40 or so minutes in the breakout rooms delving deeper into some related topics. On the screen is a list of the 6 rooms, the topics, and the presenters. Presenters will do a brief 5 to 7 minute presentation, and then the rest of the time will be spent hearing from other people in the room. We want you to feel free to ask questions of the presenter, to share information about what you're doing in your state around your room's topic, ask questions of each other, and just gather more information. We hear a lot from participants in our universal webinars that you guys really want more time to be able to talk with each other and delve a little bit deeper and ask questions. And so we're hoping that having this many breakout rooms will provide that opportunity for you today. There will be a facilitator in each room. There are some facilitation questions. If we get to them, great. If the conversation is going well without it, that's even better. Excuse me. All of the breakout room conversations are going to be recorded so that people can go back and listen to the conversations in rooms that they aren't able to attend. Because the other thing is, even though we didn't assign people to rooms because we want you to go where your interests lie, we do, however, want you to stay in the room that you choose the entire time. So because there's going to be a 5 to 7 minute presentation, if you hop around to different rooms, you'll miss what was presented. So I don't think you would be able to participate as effectively if you miss that. So, all right. It is time for everybody to be able to choose their breakout room. So Marissa, can you put that up on the screen? Hello, welcome back. Thank you all so much for staying and participating in the breakout rooms. I'm sure there was some lively conversation, and I hope that you all learned something new. Now, if you will just take a few minutes to answer the evaluation questions that pop up on your screen, we would really appreciate it. And then we will wrap up. So there are 3 different questions. If you'll just take a few minutes and answer, we'd appreciate it. After you answer the first question, if you scroll down, there are 2 additional open-ended questions. Yeah, so the second question was just so in case anybody closed their poll before they saw the other 2 questions, sorry about that. The second question was, are there any topics in addition to those listed in question number 1 that you would like to hear more about related to infant and early childhood mental health? And it's open-ended, so you can just put that answer in the chat if you'd like. And then the third question was, is there anything else you'd like to share with us as we plan future webinars? Also a short answer question, so if you want to put any feedback for us in the chat, we'd really appreciate it. Oh, I see Kim says, if you click on polls at the bottom of the screen, it may come back up. So we'll give it just a few more seconds since we have some time. All right, Courtney, I think we can go ahead and close those polls, and we'll just go in the chat and see what kind of answers there are there as well. But thank you guys again for attending today's webinar. We appreciate it. We know an hour and a half is a lot of your day to give up, but this is a really important topic. So we're glad that you were here. I'd like to thank all the presenters and all the participants and all of the technical support that it took to get today's webinar off. So I hope everybody found it a valuable use of your time, and have a great rest of your day. Thanks so much.